Now it goes.
Okay, welcome to today's webinar, Modernizing the EHR for Clinical Advancement, Our Journey with Oracle Health Solutions with Mississippi Band and Choctaw Indians. I'm going to turn it over. If you can hold your questions until the question and answer session, that would be wonderful. So I'll turn it over to Millicent and Audrey and the Mississippi Band and Choctaw team.
Thank you, Brian. I'm kind of manning the camera behind here, so I'll be going back and forth in view. But good morning, or good afternoon, depending on where you are. It is a pleasure for us to provide this presentation for you from the Choctaw Health Center. What I will do is go ahead and share the screen for our presentation. It is an audio presentation, so if you could just bear with me for just a moment, we'll get that situated. Are you on your start stage? With insurance. Yes. Yeah. Do the sound share. Brian, can you see that first screen? We don't see the content.
I see the PowerPoint.
Yeah, that's what this is. Don't see the whole thing. Okay, but I can play now. Try to click on it and we'll see how it looks. No, it's not. We still see the whole. Yeah, there it goes. You got it.
That works.
All right, we're going to go around the room right quick just to give a general introduction. So, like we mentioned, my name is Millicent Wallace. I'm the Director of Nursing here. I've been at the Choctaw Health Center for 18 years. I have been working as the clinical lead for this project. Next to me, I'm going to go ahead and kick it off back to Audrey.
Hi, good afternoon. My name is Audrey Thomas. My background is nursing. I've been a nurse for 17 years. My title here, my role with Oracle is a clinical project specialist, basically a project manager, overseeing the implementation. And thank you all for inviting us and letting us share our story. I'll pass it on to Leslie.
Hey, good afternoon, everybody. My name is Leslie Wallace. Welcome, USAID in Nashville area. I'm the Quality Management Coordinator here at Choctaw Health Center. I've been here for a good while. My background is in coding for over 20 years. But for the Oracle project, I stepped up and I served as the Education Coordinator and the Integration Lead, with support also as a subject matter expert and a super user. I've also served on the various teams and committees that we had to develop in support of the Oracle project. I've been at Choctaw Health Center for 34 years, and I've been through RPMS PCC, RPMS PCC Plus, and RPMS EHR, and now I've landed on Oracle Healthcare. I'm very pleased that you have all chosen to attend and listen to our journey. And I'll now give it to Stephanie.
Hey, I'm Stephanie Langford. For 25 years, I cared for patients here as a dental hygienist at Choctaw Health Center. During that time, I learned that delivering care depends on more than clinical skills. It takes the right tools, systems, and support behind the scenes. And I have been working with Audrey on the project with Oracle. I'm gonna turn it over to Casey.
Hi, my name is Casey Willis. I'm the managed care director here at Choctaw Health Center. My background is in nursing. I've been here for almost 18 years. For the Oracle project, I served on the acute case management, the hospital registration, and also the referral management piece for our purchase referral care. Go ahead, David.
Good afternoon, good morning. My name is Derek Brown. I'm the Director of Plant Operations and Maintenance here at CHC. Been with the organization for 8 years, and in my normal role, I oversee capital projects, infrastructure improvements, facility maintenance, compliance initiatives, and other large-scale organizational projects. With the EHR conversion, I was assigned as the technical lead, anticipating being primarily involved in the technical aspects of the transition. But because many of those highly specialized tasks were handled by our IT team, the IT director and his team, who handled those tasks very well, my role ended up transitioning into one that was more project leadership, coordination, that sort of thing, helping facilitate communication amongst departments, ensuring accountability, removing barriers between departments, with a look at the overall big picture of the goals that we wanted to obtain with this conversion. Ray?
I'm Ray Willis. I am the network administrator here at the hospital. I've been working here for about 25 years. As Derek stated, our IT team did a lot of work here, so we're ready to present to you guys. We have Myrna back here.
We're just doing quick introductions if you guys would like
I'm
to.
Hancock, I'm senior healthcare accountant, and I was actively involved in the transition to Oracle with the revenue cycle.
Doug, if you want to go ahead and introduce yourself and what you did with the project.
Okay. I'm Douglas Weaver, the interim financial director for Choctaw Health Center. And was on the steering committee for the project.
Hello, I'm Dr. Christina Wallace. I am the Chief Medical Officer here at the Choctaw Health Center. Have been with our organization for about 3 years. Initially here as a internal medicine physician working in a primary care clinic and also inpatient. We've had a lot of work as far as our providers and learning the system and you know, now really do work together to train one another as we have new staff coming on board, and learned a lot through this process of integration of a new electronic health record system.
All right, those are our team members who are in the room for presentation today. So we will get started. If you would like to go ahead and enter any of your questions into the chat, that would be great. We can answer those at the end. And we are also welcoming any Q&As at the end of the presentation as well. If you would like to turn up the volume, we do have the presentation pre-recorded. We'll just be sitting around the room waiting for that to complete.
We want to share our experience and milestones of the EHR modernization at Choctaw Health Center, and will follow the agenda topics you see here. Our expectation was to formulate a partnership with the Oracle team to implement an adaptable and advanced technology system. We chose our new EHR partner with a mutual understanding of addressing our specific limitations to offer an interoperability experience by reducing documentation concerns, streamlining reports, and providing quality information that supports our strategic decisions under the foundation of automated business processes, enhanced resources, and reinforced financial management and reporting.
The project vision. Throughout this implementation, we were guided by 3 principles that helped shape the decisions we made. People represents our patients and staff, the individuals we serve, and the reason this work matters. Our purpose is to provide safe, high-quality, culturally respectful care. The possibility of modern technology gives us room to grow, connect better with other systems, and to build something that will last. People, purpose, and possibility was our guiding principle. It helped us to stay focused on who we were doing this for, why it mattered, and what we could do moving forward. To appreciate the progress we've made, it's important to understand where we started. In 2016, we began exploring the possibility of transitioning to a new electronic health record system. After evaluating 3 commercial off-the-shelf solutions, we selected Cerner CommunityWorks to move us forward. When this project began, we were working with Cerner, and during the implementation, Oracle acquired Cerner, so what was once Cerner is now Oracle Health. While RPMS served us well for many years, it could no longer meet our changing needs. The limitations included the inability to support true bidirectional data flow with external systems, an unreliable patient portal, the risk of regulatory penalties due to missing reporting capabilities, and we needed to align with upcoming IHS modernization efforts. For the staff, Cerner promised a system that was easier to use with faster access to information and more time focused on patient care instead of struggling with the system. It also assured more consistent workflows, improved communication between departments, and better access to information needed to make day-to-day tasks more efficient. For the organization, it offered better data, improved reporting, and a platform designed to grow with us. It also intended to provide stronger tools for decision-making, support regulatory and reporting requirements, and create opportunities for future integrations, services, and system enhancements. For patients, it meant shorter wait times, a more reliable patient portal, helpful reminders, and an overall smoother healthcare experience. The challenges we were facing, along with the opportunities ahead, are what motivated us to make the change.
Our project objectives. We developed our project charter based on our partnership with Whitley and Oracle's model to outline the scope and effort. The charter provided CHC with a baseline for estimating effort and timeframes, serving as a reference document for project team members. The framework confirms the roles and responsibilities for team members to allow for timely completion of scheduled activities. The charter confirms the commitment of CHC and the team to the project. Our objectives remained realistic. We wanted to improve clinical workflows and patient outcomes, create a modern, user-friendly EHR experience, achieve regulatory compliance and reporting efficiency, support staff with structured training and change management, automate processes that were previously manual and time-consuming, sustain long-term EHR performance and readiness for future enhancements. These objectives set the foundation not just for the project's success, but for the future of healthcare delivery within MBCI.
When we began implementing a new EMR at Choctaw Health Center, we quickly realized just how many factors we needed to consider. Our team identified 4 pillars that became the foundation of our project plan: budget consideration, resources, engagement, and technology needs. Financial implications will vary depending on your organization's specific needs, including the ability to invest in the many applications offered by commercial off-the-shelf systems, COTS. Training and ongoing staff engagement were crucial for our success. To keep everyone informed, we started a monthly newsletter. something we'll elaborate on later. We also had to carefully assess our technology and infrastructure and determine how best to manage necessary upgrades. Our journey was truly a team effort. We relied on cross-functional teams, clear communication, and well-defined responsibilities to address issues as they arose. Throughout the build, we embraced progressive documentation, validated workflows together, and followed a structured project governance framework. Thanks to everyone's dedication and coordination, we achieved a smooth go live that benefited our entire organization.
The technical aspects of modernization were substantial. Our teams executed a rigorous data migration and validation process, strengthened our network and infrastructure, and advanced cybersecurity protections. We standardized devices and printers, mapped interfaces, and conducted thorough readiness testing. This work was essential to ensuring uninterrupted patient care throughout our project and beyond go live. We have listed the major findings in our technical assessment here. Infrastructure upgrades such as widespread Wi-Fi, server upgrades, and additional hardware should be considered. Vendor collaboration involves software updates and network connectivity between Oracle, the chosen vendor, and the organization. Our critical needs included retrieving results and establishing system integration. Interoperability challenges included the database integrity, accessibility, and readability issues. The lack of data standards hindered data transfers. Further, the internal and external system had connectivity issues. Collaboration and testing, extensive coordination between CHC IT, Oracle, and third-party vendors to ensure integration were key to ensure project deliverables were met timely.
EHR modernization requires careful financial governance and oversight. Our budgeting initially focused on infrastructure readiness, software licensing, technical support, staff training, and go-live resourcing. We evaluated both short and long-term cost impacts, ensuring alignment with CHC's strategic direction and financial sustainability. Resource allocation also helped us maintain scope, avoid delays, and support our teams throughout the transition. From a financial and operational standpoint, the new system significantly improves our performance. We now have more streamlined collection workflows across the patient care spectrum, and the new platform provides better visibility into every stage of the patient journey. It is important that we remind our tribal healthcare partners that recurring fees are imminent for several applications in addition to the initial Oracle project costs.
To encourage engagement, assist with learning, and help facilitate project adoption, we incorporated the theme First Down to Touchdown. The concept behind our theme was to emphasize the need for teamwork, which was reiterated via a monthly newsletter. We tracked the progress of the implementation by noting and communicating key project journey milestones. Whether it was the early discussions while the idea was in its infancy stage, the creation and acceptance of the project charter, the assemblance of the core team members, staff training, or the announcement of the much anticipated go live date. The key project journey milestones were adequately tracked and appropriately communicated.
Lessons learned and recommendations for tribal leaders. Effective communication and understanding, team engagement and roles, timely issue resolution and progressive build, preparation and documentation, project planning. Successful EHR system transitions rely on effective teamwork, thorough planning, and clear communication. All parties must have a shared understanding of goals and timelines, with key information provided early to prevent disruption. It is crucial to involve the entire facility, ensuring everyone is aligned with the project. Resolving issues promptly is also key. Careful documentation and ongoing change management will help ensure a smooth transition. Additionally, vendors and consultants must communicate and collaborate effectively, with adequate time and resources allocated for staffing and system improvements to manage daily operations during the project. As with any major transformation, this journey has taught us a great deal. Communication was instrumental, role clarity prevented delays, and strong buy-in protected continuity. Comprehensive planning reduced risk, and most importantly, engagement from leadership to frontline staff was the single greatest driver of our success. These lessons will support not only future technology transitions, but organizational change efforts across Choctaw Health Center.
Yakoke, thank you for allowing us the opportunity to share a small piece of our journey with you. The modernization reflects a shared commitment to the health of the Choctaw people and the future of our healthcare system. We're happy to answer any questions and can be reached anytime at our email listed here.
We can open it up for questions now if anybody has any questions to start out. We have one comment in the question or in the chat. How did you incorporate PRC?
So for us, with the community works, we utilize the referral management piece in the acute care application. We made it work for us. So, but we are able to send out the referrals directly from the system with all the necessary documents attached. We did have to get another application for claims processing. We went with Plexus Healthcare for that.
Is he talking right now?
I have a question. How was it with reporting to IHS for GIPRA or any other things that you had to report to IHS on? Was it difficult to pull the information out of Cerner?
Actually, when we first started, we went live in April, and then we began Phase X in August. And that's when one of the apps that we were given was I2I Tracks. And I2I Tracks was the application that was to pull all the GIPRA data. From our side, we did have a lot of GIPRA data. It was more or less maybe the export. I think we had to do some configuration, but the data is there. Our staff were trained on where to document in order for that data to make sure that it crossed over correctly. Oracle was aware of the GIPRA standards, and so that was pretty easy there. And I2I, of course, also was aware of GIPRA. So right now, that's where we stand as far as getting the export there. I've shared the report from I2I with the Nashville area office, I guess. But sometimes it's there and sometimes it's not there. I'm not going to say that we didn't have some kinks. We did. But we're working it out. And I believe the last one we had perhaps this data, that's one that kind of is a thorn in our side at the moment. But as far as reports we do that we pull from I2I, it's very substantial as far as our Gifford data.
Okay. Right, thank you. There's two questions in the chat that they want you to repeat the name of the program that you used for PRC, or the company you used for PRC.
For the
If you
claims
could write it in the
process.
chat. And they also want your email. Back up the CHC Oracle.
Okay, we can send that. We'll add that to the chat.
Okay. And Morgan has a question on SDP audit reports. How was it for pulling that data?
That again was pulled by I2I Systems. The consultant actually had to help the diabetes director develop the reports for that. And but the data was submitted the way it was supposed to be. The thing about that, a lot of the reports had to be written and developed. On the front end, maybe one of the things we need to thoroughly stress is that all IHS reports that are mandatory and required, you have got to document it now that it's going to be needed, so that on the front end, before you start, while you're in development, that those reports can also be developed. We had a few instances where that was not done, and we had to backtrack and get it done. But it is there, it is possible. It's not like you can't do it, it is there. But that is one thing that we have to thoroughly stress, that write down every report, those canned reports that are in RPMS that you use every day, those that are due monthly, yearly, make sure they're all documented so that when you're on the front end of starting any new system that, hey, we're going to need this in the long run, not after you get going, but before you get going.
Were those add-ons that you had to put into your system? Like, did they come with the EHR program, or did you have to put them as add-ons? Did you have to pay separately for them?
We paid.
separately.
Yes, we did. We paid for that application. That's correct.
So
And
I have a
Michelle
ton
had
of
a-
questions.
Okay,
Sorry.
Sorry, go ahead. Ask your
I
question.
put some in the chat, but you had mentioned some of the you had to buy your server and your hardware. So the Oracle doesn't store the information for you. You store it all on your own server.
No, they do host it, but we just wanted to upgrade our infrastructure just in case we ran into any problems, and they said some of our hardware was the problem. So we just went ahead and did that on the front end.
Okay. And with the migration of data, how did that go, and how far back did they go with, how many years back did they go with your data migration?
We went back 7 years on the data migration. And when we did migrate it, it was done in several different steps, which didn't take too long, but it happened maybe a couple of days, maybe a day or so.
Selected what data we wanted.
And it was just 7 years back on the data. And we did a we had a selection of what we wanted to move over.
You were talking about the servers also. We did get to visit the facility that, one of the facilities where they store all the data. And it's very secure. I gotta say, very secure. It's underground. It's set up to withstand an F5. Who all went?
Oh,
an F5 tornado, flooding. But I believe they now have 3 sites that host all of the data. If it was to go down, they're automatically on it to bring it back up to us and to restore us. The only thing that affects us is if we go down here, and that's about it. Otherwise, we're continually on.
And Teresa has a question in the chat. How many registered patients, and can you speak to its function for ambulatory clinic?
Our user clock now is around 10:09 or so.
Yeah, the user clock right now is at probably 10,000 plus. In the ambulatory clinic, are you talking about registering patients in the ambulatory or?
Hi there. Yeah, this is Teresa. I'm just looking for the difference. Obviously, a hospital would be more complex, probably of needs, the ability to do orders for radiology and so forth. Where we're ambulatory, we do a lot of referral. So I'm just curious to know, did that setup look different for the ambulatory clinic compared to hospital, if you have that situation?
Like the difference between like our primary care department and then versus our hospital admissions or the emergency room?
Yes.
So no,
Yeah.
it didn't look too different. They do operate out of 2 separate applications. One is FirstNet and the other is CareNet. So they are 2 separate applications, but you know, they function in the same. We still have to operate by all of our guidelines that we use for referrals and sending patients out.
Okay.
Yeah, so it wasn't, it's not too big of an issue, I would say here. We still see well over 130, maybe 140 patients per day. And that's just in the primary care, emergency room, and inpatient settings. We do have other clinics available as well.
Okay. Thank you.
Thank you.
Going back to your comment about using Plexus, do they do all of your purchase and referred care? Do you have somebody in there that's actually has a role in PRC for authorizing? Do they just cut your checks? How does all of that work for your PRC program? And is it connected in any way to your EHR?
So Plexus is where we create all of the requisitions. We still pay through our travel finance, but they did create reports and the requisitions for us. Oracle helped us create an actual report to get the data from Oracle to upload into Plexus. But we still pay through our travel finance.
Okay, thank you.
When you pay through your travel finance, are you connected in any way that you can export your information to your travel finance, or is that another step, like a process of which you enter that into your travel finance?
So when the information's entered into Plexus, it does provide that report and stuff for us to submit to our travel finance.
Okay, thank you.
And I have a question from someone. Do you have a spot for mortality data in the new system? Or are y'all still utilizing the RPMS system for that?
Actually, our RPMS is just a what do you call it? Historical data. Yeah, we can't enter anything into RPMS right now. So if a death does occur in our inpatient department, there is a way to gather all that information that normally I did put into RPMS. But however, if the death occurred off-site or somewhere else, then it's entered through our health information department, and it's limited data right now. we have questioned and asked before to have that, you know, that ability to put it in like I did before. Because we do still get that information from our, the state for, deaths that occurred offsite. But the ability to put every one of them in still doesn't exist. Just the date of death, license, I mean, the death certificate number. But those other fields that you have on there, how, where, homicides and the multiple, ICD-10 codes that we used to put in, that does not exist right now.
Okay, thank you so much. I'm not plugging anything in this, but I'm going to mention that we are building a mortality repository that is not in RPMS. So you will be able to have access to that system to enter the data in. So don't worry, it's coming.
Right.
And there's a question in the chat. Can you speak more about your internal project management? What delegation of work was on the different tribal nation departments and staff versus your contractors? How did you coordinate your work internally?
Well, yeah, that took a lot of effort. We do have our steering committee that we have, and it involves, the group that you see here at the table, as well as, of course, our health director. We did develop a project charter to help us guide us through this project. We had the assistance of a third-party vendor, Whitfleet, and they had two project managers that helped us guide us through this project as well. So a lot of hands on deck, a lot of multiple hats, people, we had our subject matter experts that we assigned for the different various departments. We had our super users that we assigned. So it took a lot of teamwork to make it happen.
In addition, we had weekly project calls that occurred. Sometimes it was
Daily.
daily. Initially it was daily calls, and they wanted to gather as much information that we could give them. So when Leslie mentioned, talking about those reports and things that, she was saying department owners needed to provide to the consultants, that's the kind of stuff that we needed. We needed active participation. So finding those individuals who had the buy-in, who wanted this project to work, who, anticipated better processes for their own departments, that's something that we had to recognize within our team. Understanding that, getting on these calls and asking questions to those consultants, because a lot of the consultants didn't know what, IHS was or how a tribal facility operated. We did have to be very patient with that, and they were patient as well on their end. So they would take questions back to whether it was their project managers or their leads to ask, because they haven't ever dealt with a system like ours. So it was a challenge, but I think that as long as you have those active participants, you identify those team members who can assist with developing those processes, then, I think you'll be fine. But if you don't have that, I'm sorry. It'll be a little difficult, but you can still make it. Fortunately, we work closely together, and this team here, we really tried to make sure that we incorporated everything we needed as Choctaw Health Center to better serve our patients. Hope that answered your question. If not, we can elaborate a little more.
Great. Thank you. Michelle has two questions in the chat. Are you open to having other tribes visit so they can see more firsthand how your system works? And did you hire any consultants throughout the process?
Actually, we have Cherokee coming to visit on site here in the next few months. So we're excited for that site visit. And yes, we are open to other tribal facilities. Anyone who wants to come and sit down and hang out with us, that'll be great. As far as other consultants, as I think when we reached out, we had several vendors. So you're always going to have to work with vendors. We had, for example, I have this Siemens Accelerator project that we're actively implementing now. And that's only because we're obtaining new equipment. So I have a vendor that I'm working with Siemens, and then I also have Oracle, and then we also have our internal IT team here. So we're all working together in that sense to make sure that this project is interfaced and for seamless transmission of our lab results and point of care testing devices. So those types of things, yes, we do have several consultants that we work with, but my majority it's within Oracle.
And you heard me mention Phase X a while ago. That's when we went into another version of Oracle. And we had some more consultants come on at that time. Like we had one for hospital compare reports. And we also had one that was for our regulatory reports. And we still, at the moment, the hospital compare dropped off and they're still in the background, but we still consult with them when we need them. But the regulatory consultant, he's still on getting us with our ECQMs and our, what was the other one? The quality net, so forth like that, just to make sure that our reports are being submitted timely and, or if we have any problems with any of it. He still meets with us bi-weekly.
I have a question. How is your ongoing relationship with them? And then do you have, I think of RPMet, like patches and so forth, and do you all do that, or is that handled through Oracle and such?
So yes, we do have an ongoing relationship with Oracle. We have a bi-weekly call that we have with the healthcare sales executive is their title. And that's our main person that if we need anything, if we have any issues, we go through her and she'll get us what we need. She'll communicate any issues that we're having to help us find a resolution. And then, of course, if there's any other issues, our internal process includes staff putting in work orders. We'll evaluate the work orders and see if we can resolve it internally. Otherwise, we'll log a ticket to Oracle through the AMS e-service ticket system, and then we'll see through and track that ticket until the resolution.
Are they fairly responsive, do you find?
They are now. In the beginning, we did have some rough patches, but I think now it's gotten a little bit better.
Yeah. Yeah. Consistency in your point of contact, or have you had multiple like changes? Like if they have staffing change, are you finding you're having constant changes, or is it just a help desk and who answers is who answers and that's who's helping kind of situation?
They have different tiers, different consultants for the say charge services has their own group of consultants. It depends on where the issue lies. But they also have IRC, what is that? Immediate response center where we can call directly if we have anything urgent that we need resolved right away. And they're pretty responsive there. They'll help us figure out what's going on pretty quickly.
When you onboarded or I guess as you went through the development phase and then you were getting ready to go live, were you able to go through a checklist with them of things and making sure it's in working order before you officially went live? And did you get to, how do I want to word that? Did you get to say when you went live that they didn't push you to go live on said date when you or your team wasn't necessarily ready to do that?
Yes, that's correct. Yeah, we had like they mentioned before, we had our weekly project management call with Oracle, and every week they went through like basically a checklist of what all we were currently working on, making sure it met what needed to be the so that we could go live.
Sure.
It's basically a checklist, like you mentioned, yes.
Okay.
And speaking on dental, this question is for dental. Are y'all still using Dentrix? Does Dentrix communicate with Cerner? And what about your satellite dental clinics? Are they part of the network or how's that work?
Yes, we are still using Dentrix, and Oracle is the source of truth. So nothing comes from Dentrix to Oracle. Everything goes from Oracle to Dentrix. We did have to do a separate build for the satellite clinics, but it is mirroring here at the health center.
Thank you.
You might have brought this up earlier in your presentation, but I was having difficulty hearing on our end just because we had some technical issues going on with our speaker. But how many other EHR products did you look at before deciding to go with Oracle, and what made Oracle stand out among all of them?
We did look at 3 different products. And one of the things I think we did, of course, our staff, they go to different providers also. The experience that they saw with different products at other facilities. But Oracle, they actually brought or took us to a site to view the product. And we were able to see firsthand the reports that were available, dashboards that were available, the support that would be needed in the end, what they would provide. For me, I was sold the first time I saw it, because I saw everything that it could do compared to what we have right now. And I still believe in it. It's just so much more than what we had before. And like we said, we started in 2016. We visited again in 2020, I believe, and then again in 21. So it's been quite a journey for just finding the product and saying, yes, this is the one we want. This is the one we're going to go with. There are hurdles along the way. We're not going to lie about that. But for me, in the end, I may not have the same view that everybody else has, but I'm sold on it.
From the time that you made your decision about what product you were going to go with, how long did it take you to from the start to your go live? How long was that process? Training and getting everything, all of your reports and your add-ons and figuring out what you needed and, regular.
We really started in 23.
Yeah, we were delayed a little bit with COVID.
And we had another delay with the Oracle Cerner and Oracle merger as well. We had one major challenge when we were in project development where our consultants were, it was the majority of our consultants were replaced. So they ended up having, was it another merger where they had a major layoff? Yeah, it was a layoff. So, those types of things where we've went through a whole year of learning who these consultants were, and then, having to learn a whole new group of individuals and them not knowing how our system operated. We had to rebuild that relationship, and but they met our go live. I think we had to extend that a few times, at least twice. We extended our go live, but that was, on our terms and of course on theirs as well because of those consultant layoffs. So it was a challenge, but we made it through. So between that time, it had to be what, 2 years
Year and a half.
or a year and a half,
Mhm.
yeah, before we went on our go live date.
Yeah, we did from October to February to April.
What type of feedback have you gotten from your patients, your community? Do they notice a difference? Meaning, like, can they connect to their provider or their nurses or get med refills easier or anything like that? Have you gotten any feedback from that perspective?
I think, yeah. I think for those that actually do use it, which would be more maybe the middle age or the younger population that's more tech savvy, they would enjoy using it. Now with Cerner, their patient portal, of course, it was great and it provided more than what our PMS did. But with Oracle, Oracle is more technology driven. They've got all this AI implementation they're doing. And so we're actually we'll be upgrading our current Cerner patient portal to the Oracle patient portal. And I think that will include more and better features than what we have right now. So that's one thing that we're looking forward to with Oracle.
Do you use the patient portal as your platform for telemedicine or any of that right now? Or no,
Yes.
you do. Yep. Okay.
And another question in the chat or comment in the chat, can you speak to the behavioral health services and if that's incorporated into Oracle as well?
Yes, they do use Oracle. Behavioral Health does. We have theirs once they register a patient, they have to set their confidentiality level to a certain level where only behavioral health staff can see what, we have to keep those records confidential. So yes, Oracle does provide what it needs to keep the HIPAA compliance and maintain privacy for our patients.
Great, great. Riz has a question in the chat. Did you have discussions with your contractors about if you ever needed to migrate back to a different platform? What would that look like? And has this interface been easily compatible with other programs for specialized functions? Do you anticipate using Oracle for a long time going forward?
So that's three different questions. Can you repeat the first one?
Yes, sorry. Did you have discussions with your contractors about if you ever needed to migrate back to a different platform and what would that look like?
I think we're so focused, Ray, on trying to. Yeah.
Yeah, we're still right in the middle. We're in the early stages. We have a 10-year contract. We're in year 2, 3. So we're still in the early stages. So no, we've not really looked at the migration back or how we'll proceed after the contract is up. So that's still something for us to discuss in the future.
What was your second question? I'm sorry, go ahead.
Yeah, the second part was, has this interface been easily compatible with other programs for specialized functions?
Right, we had to handle those on a case-by-case basis, depending on who the vendor was. Comment on that.
Those are case-by-case basis. Some require more than others. It just depends on who's calling.
And last on their question, do you anticipate using Oracle for a long time going forward? And you said you had a 10-year contract, so I assume 10 years is a long time.
Locked in. Yeah.
Just to let everyone know, we have 2 more minutes until 1 o'clock. If y'all are okay with staying for a couple more questions, I know we have a couple more questions in the chat. Is that good? Okay. Michelle asked, do you have your shares with IHS and utilize them for any technical support still?
We don't use our RPMS very much anymore. As a matter of fact, we're about to turn it off. At the beginning, we ran dual systems like RPMS and Cerner, but that was only for maybe a few days. And we're Oracle now, so we rarely use RPMS, just like for historical data. And we're about to turn that thing off because nobody should be in there right now.
Ray, will you let me know when you do that? Because we do need to pull some reports out of there for mortality.
All right.
You got 30 minutes.
Yep, got 30 minutes.
Okay. Okay, we'll get on it then. Did you experience any losses in revenue during the transition, and do you see any increases in revenue since you went live?
Oh, Doug, you want to take that?
Yeah, I can respond to that. And yes, you do have a large drop in your revenue for at least 6 to 9 months. Ours was just a little bit longer than that, but they tell you up front that there's going to be a 6 month drop in revenue. And the revenue cycle charge master consultants stay on for 3 or 4 months after the rest of the consultants go off. So you do need to anticipate or have a way to sustain your operations without the same level of revenue. But right now we're a little over 2 years into it, and we're going to hit the highest year ever. But a lot of that is making up for the backlog in the encounters that are still being coded. We're just now getting our backlog finished by the middle of August of this year. So, it's kind of like we have double encounters being billed. So that really has led to an increase in revenue. So long term, it's going to be the end of this fiscal year before we can really estimate what our revenue collections will be next year. But there are increased opportunities for optimizing the system and collecting things that you didn't do before. So, yeah, there'll be a drop.
Is your drop in revenue because you've got claims that are sitting there that aren't being coded and billed out because you're in a transition period? Is that why?
Yeah, it's because they really didn't have a good interface or really understand the per diem and the way it was built. It was very difficult, and registration was hard. It was a learning curve on our side, but also they really didn't build the billing out properly for per diem billing. They kind of created a workaround that dropped the per diem at the point of registration. So that caused some problems. And it took a long time to get all the service tickets cleaned up, where we did have a clean bill. But it's running a lot smoother now. And like I said, we will have 23, fiscal year 23 was our highest ever, and we're going to beat that quite a bit this year.
And does Oracle support the health information exchange, and can you receive data bidirectionally from your system?
Yeah, we have the health information that's automatically built in. The only thing we have to do is if the patient does not want, if we alert them that their information is going bi-directional, if they want to opt out for it, but otherwise everyone's already locked into it.
Okay, great. And I have a follow-up question to that. So you're able to link to like the state immunization registry and things like that?
Oh, that we're working on.
Okay.
We discovered that after we went live. We are getting from the state, but going back to the state, we can't import their data, but we can export our data.
Okay. And anybody else have any questions? That's it for the chat. And I have one final question, if no one else has anything. What is your biggest lesson learned throughout this experience? Something that you didn't think of or you didn't do that you wish you would have thought of or done before you went live or began this process?
For me, I think identifying someone who can be dedicated to the project. Audrey had mentioned that she was her background was in nursing, and she was actually the primary care nurse supervisor. So she was on the ambulatory side. When the project started and throughout implementation, we had an individual who was dedicated. She ended up leaving that position, and ultimately Audrey stepped in. So I think if we and also Stephanie came out from the dental department as well. And so those two were identified to solely have all of their efforts based on the project. I think if we could have had maybe a few more people that would have been dedicated to it, it would have taken some of the load off of, other individuals. But I think that if you guys could implement something like that within your own healthcare facility, that would be great. Also having your champions, those team members who you've identified throughout, working here or working in your facility. We had physician champions and nurse champions and people who were subject matter experts that we identified. Having a great team to have that in place, I think is so important and vital to your success. What about PRC?
Really would have been better to have a better understanding of capabilities related to PRC. The application that we picked was, it does integrate, but there's a lot of room for improvement, having a better solution for that. And there's more available now, I think, than there was 3 or 4 years ago.
It's true. And really having them understand what a tribal facility is and how it operates, I think would be a good start for any organization as well.
Can we get your consultant's name?
Yes,
I was going to say that too.
That would be, one of the takeaways, I think, to really get to know who we spoke to and who we worked with. And even, if you want to ask us, hey, how did this work for you guys? We're open to that. So please send us an email. We'll be willing to help any way we can. And come visit us.
I think, yeah, we definitely are interested. And, thank you guys so much for offering all this information. It really is much appreciated.
Thank you.
Yes, thank you.
Does anybody else have any questions or comments? And Teresa said you seem to be an amazing team, and thank you for sharing today.
Thank you, Teresa.
Yes, thank you. I can only imagine the workload that was behind that. I've done a smaller implementation, but it takes commitment, dedication, probably a lot of venting and walks and, wanting to bang your head. So much respect.
I'll admit, when she talked about the daily meetings, they were back to back, 9, 10, 11, 12. And sometimes during that day, I was on the laptop, I was on the desktop, I was on the iPad, all at the same time, attending 3 meetings at one time.
Yeah.
But you're a superstar.
Yes. I think we all did that, so they're all stars.
Does anybody else have any questions or comments before we wrap up? Okay. Well, I think that ends it for today. Thank you so much for that wonderful and very informative presentation. We did record this, so if it's okay, we'll share it. Yep. And thank you so much. Y'all have a great day.
Thank
All right, thank you. Same here.
Bye. Wait
Bye-bye.
on that with registry to Brian.
Mhm.